Now again, you don't have any paint, you don't put up on the table.
It's too small.
Do you get it? Generally?
Only recently it's started.
Only recently said, okay. Great.
Cheap diagnosis, that's all I'm looking for.
Yeah, get that now, yeah, get that.
Cheap, actually.
Yeah.
No.
Yeah, it works out
No,
pretty clear, all right.
it's very
So we're just going to pop that in along the pubic range now, okay? That's okay. You can find it on the top of that triangle. Right down there. And again, it's going to be tender, isn't it? Like really winding with there. No bulge. Hang in there, okay? Now on top of the pubic range there. Okay? You would expect it. See what there? That's not what you're getting, but where do you normally get your pen? Right in there, isn't it? Okay.
Yeah, sure would. Thanks, Santos.
Your responsibility is now being planned. See both of them talk as well. You two. Just go. Let me take you saying. Yeah, it is.
You know, Fina.
Hello.
Huh? You know, Fina. You're close in there, see? Something like that.
Can we get back over? So, palpating in there. In the anterior. You okay there? That's tender there, is it? Okay. So we're on a adductor tendon in around there, and that is tender. All that there, yeah? And is that the most tender? Ooh, that's so far. Probably is, isn't it? I'm kind of using the same pressure all the way along. That's your pain there? Is that where you get it, or is it more higher?
It seems to be weird.
Higher a little bit in there, yeah. Okay. No, you're not focused on. So, let's consider broadly, because we're taking a super structural anatomical approach here. We've kind of skipped, because I wanted to get straight to palpation, we've only got an hour and a half today, so we get this done. But, if we were looking at differential diagnosis for lower right quadrant and chronic pain, give me some differentials while we're at it.
Fracture. Fracture. Femoral neck.
Fracture femoral neck. Yeah, gynecological issues, yeah. So is our screening going to need to be, and we haven't covered it today in here, we'll put up some screening questions for this again. But again, is that going to have to be a little bit more elaborate in this case, in our genitourinary screening and all that? Is that going to have to be done in these kind of cases? For sure it is, absolutely it is. Yeah, is that so where you calculate, is it? No? Perfect. Not so where you're got a bathroom like that? No? Perfect. Brilliant. Yeah, so this is mechanical. But again, you got to take all that in mind. You're looking for menstrual changes, all that kind of stuff as well, and you got to have your screening questionnaire there. To be honest, when I'm doing it with clinic, I actually use it like a tick box. I go through them like that. And if I really don't want to ask a question, I'll say, "Can you fill that out?" Thank you very much. Covers my ass. What I know, and someone's going to be So, bear in mind, we're looking at this. We are confirmed to bias is towards mechanical and biomechanical and sports medicine and all that, so it's worth remembering there's other stuff going on there too. So that's the palpation part. Now I'm just going to do this because I can't not. You okay there? Oh, that's nice, that's good. You play sport, don't you? How does that feel there? That's okay there, yeah? That's good. How you doing there? No pain, no nothing, no? Perfect.
Did you do a Scowers test maybe?
Just give me a fucking minute.
I was here yesterday, you know if you want your name or not.
No, you were just waiting here for my class yesterday. How's that there? Pretty good? Tight in the groin there, yeah. So, it's that kind of an FAI doesn't look like that. Okay, hip arthritis doesn't look like that. And we could do our Scour test then again. But again, you're probably going to get pain in the Scour test. In there a little bit, there, yeah. So, but again, when we do a Scour test, are we just isolating the joint and testing that? Isolating the labrum and testing that? Is that what we're doing? No, we're kind of testing anything that's stuck in that space in there as well. So it wouldn't be too worried. We're going to cover it. You don't know. Trust me. It's at the end of the nose. Okay. Now, does that look like hip away? No. Okay. Now, if you got a hypermobile, if you had a hypermobile person, you can get a false negative on that, but I don't think that's Dara. We're talking really oriental people here who are super mobile. I've come across that in China, but that's not Dara. Dara's normal and mobility stress. Don't worry about that. He didn't like that. Have you women folk don't do that way. Are you going to take a job? There you go. So an FAI, but what it can look like is this. When we get into flexion here, the leg starts to drive out that way because it's literally got bone on bone over in the pubes in there. And then you can have them, by the way, and if you're not in a twisty, turny sport, you can, or if you can develop techniques to work around it, you can be fine. I've got a couple of FAIs who've been diagnosed with fine. It doesn't, you know, doesn't affect me. But I'm old. I'm a proper fat. That's okay there, isn't it? Now that's a lovely springy end feel there. If you had a hip away, but that feels like it's, you know, a chub lock. You know, it's chub lock. It's like that. Bang. It's a hard end feel. If you get a bad enough away, it's a hard end feel. This is nice. We get in here. You can feel the capsule springing. Are we getting about 45 degrees internal rotation? Absolutely. Yeah. So, you know, we want to compare to the other side, obviously, but to me, it's within normal. Faber's test is negative. We do have tenderness of the soft tissues in the area there. So I'd say this is most likely what you're experiencing day to day is most likely quite a benign pain, but you're getting a soft tissue type of sensitivity and whatever else, and a bit of treatment and a bit of strengthening. You have no problem whatsoever. You get another good 30 years out of that hip, and then we go look at it again, and you get another 10 years out of that, and then we give you a new one. By that stage, they'll be just putting in stem cell injections. So, anyway, there's the idea. We'll have you first off, get your patient, drape them up, get your informed consent, define that triangle. And there, you can use that diagram to define the triangle. And using the two hands, you're going to palpate first the lateral to the triangle, then you're going to go superior to the triangle, and you're going to go inside the triangle, and then you're going to go into the adductors and inferior to the triangle. This is your palpating hands, this is your pressure hands. So this hand, both hands don't have to push. One hand's relaxed on there, the other hand is doing the pressure. You with me? Means one hand can do the thing. Right? Off you go, lads. Not a bother.